Congrats to all of you for matching. This is a big achievement by itself, and I bet you're a bit nervous about starting your intern year and have many questions about how to excel in your intern year, what to do, what should I not do now. And in today's webinar, we're going to try to share some of my advice that I give to many of interns who work with me or students who are going to intern year, how to be efficient at pre-rounding. I don't know if any of you have, done observerships, but usually the structure of the day for an intern is, let's say you assign internal medicine ward. The most common rotation you're gonna do in intern year, where you're supposed to go in there and cover the admitted patient to the internal medicine service who could have any medical condition. And this is called wards, usually, this rotation. You're gonna do it at least 4 to 6 months a year. It could be more as some program. The way this goes is that you come in the morning, you go to the night float or the night team who's been cross covering those patients, and you first thing you do when you make it to the hospital, take the sign out from them. That's usually either a printed list of your patients that's available through many electronic medical records, just print it. And then you go talk to them and they'll tell you what happened to each patient. This is the first step. Two is that, okay, I know what happened to each patient. I got the info from the sign out. I'm now gonna go start my chart checking process. So you sit down on your computer, you have your list already printed, and you're trying to review each patient. And people ask, what's the right way to do this? Well, there is one. And that's at least the one I've done and it's been working well. The first thing is to look for overnight events. So did the night float tell me there's something major about this patient or not? Two, I open up the chart and I usually look if the nurse dropped in a note over time. If there's a major event, they'll drop a note. So I'll go to the notes tab and I'll look, oh my God, like he bled. Sometimes even the night float don't know. And the nurse is like trying to manage it herself. Oh, he was hypoxemic, so I put him on 2 liters of oxygen. It was back to normal. So I just kept him on oxygen overnight. Why did the nurse keep him on oxygen overnight? So, just write that down. Like now he's on oxygen. I have to figure it out at one point. So another thing that also get missed is that if you call a consult, let's say you called me a GI consult, and usually each service has different work hours. For us, we are scoping to like around 5 p.m. Then we're writing notes. You might be gone by 5 p.m. and I'm writing notes at 7 p.m. Okay. And although I usually give you the recommendations over the phone, but when I write them, sometimes things change. And, usually not all fellows will call you back about those minor changes. So you have to also look when you look at if there's any nurse's note overnight, look for any late consultant notes. Did they suggest anything? Did they change their recommendation? What did they say? After this, you go to the vitals tab. You need to take a look not only at the last set of vitals, but over the last 24 hours, because you're pre-charting for the last 24 hours since you last took a look at it technically. And I usually try to summarize when I write down on that piece of paper. First is the patient, what's the T max, the max temperature? The heart rate, instead of using a number, I usually put a range. Like it was ranging from 60 to 80. The blood pressure has been ranging between this and this. The oxygen is 96%, but now on 2 liters instead of room air. So there's something new that happened. The next section to review is the data. So you went from vitals, now you go to the lab. You look at not only the lab of the day, similar to vitals, you want the trend. Some people think, oh, it's like a hemoglobin of 14 is normal, but what if the hemoglobin was 16 yesterday? It's absolutely not normal. The patient might be bleeding. So always have a trend of certain things. Get used to those fish bones. If you never use them, there's like a way where you do the CBC, the BMP, the LFTs. You have this fish bone. You can fill up those numbers. Come up with your own fish bone. Hopefully use one that's standardized so you can write down those numbers. Certain lab values, it's helpful to have also the yesterday number next to it. For example, for a GI bleed, I always gonna have the last two hemoglobins. So today hemoglobin is 13, yesterday was 15. So for others, patients have AKI. So creatinine was 1.0 2 yesterday, now it's 1.5. It's going up. So write those. And then not only the labs, remember there's also imaging or other tests you order. You might have ordered an echo, cardiogram. You might have ordered a chest x-ray for the patient with shortness of breath. So review these. If there's anything major, just write down briefly. Like I know it feels like you're writing a lot. You're gonna do that for the first 6 months. Then you'll memorize these. You'll be like, oh yeah, I remember this patient. The x-ray showed this. But first time, you're not gonna remember anything. So write down chest x-ray. I simply say clear, edema, pneumonia. You don't have to even go into those fine details of, oh, it's left lower lobe. No, it's just pneumonia. The next is reviewing the medication list. It's very important to take a look at it every single day because sometimes certain medications that you ordered on admission that you think are being continued, they could expire. The antibiotic is only approved for 48 hours till you prove there's an infection. And you proved an infection and you never renewed the antibiotic order. The patient's running on day 3 and 4 without antibiotics. So you have to look at the medication list. Usually, most of the ways in Epic or other electronic medical records, when you're rounding, there's easy to look at it on your phone, or when you print that list, sometimes you can also have the medication list on that list. But try to take a look at them. Make sure, for example, if the patient is going for an endoscopy for GI and they ask you to hold Lovenox the day of the procedure, make sure to hold it in the morning. So you just have to discontinue it. Then another thing you could do before you go start seeing patients is fixing some simple stuff. We always like the potassium and magnesium corrected to potassium above 4, magnesium above 2 is the normal lower cutoff. And there's always in all workrooms a way to know how much to give to get it to 2 to get it to 4. First week, maybe you don't know that yet, but it's always something you'll do after you round. They'll tell you, did you replenish the potassium? Did you replenish the magnesium? And say, oh, let me do it now. By the time you do it and you order it and the pharmacy approves it, the medication will not gonna be given till 3 p.m. Okay. But if you when you pre-round at 7 a.m. and you already realize the mag and potassium are low and you put an order for magnesium, put an order for potassium, these will be given by the time you're rounding, and that will fix the problem. And then now that you've chart checked all of your patients, so I reviewed all those 10 patients I had. Now I have to go pre-round. Pre-round mean I have to go see these patients before the actual round with the attending and my senior. The right order of pre-rounding is based on acuity. So if that patient is now on oxygen overnight, who was not, is likely the top on your list to see, instead of the one who's waiting for a nursing home placement and he's been in the hospital chilling for 4 days. So organize it by acuity. Sometimes it's hard because they're next door and you don't want to go to sixth floor, go back to the fourth floor, go up the sixth floor. Yeah, but then try to pick the first patient and the second patient that you have to see, especially if the night float told you they were worried about, the night float told you there's something, the rapid response was called overnight or something about this patient. That's the patient you need to see first. When you go to see your patient, be focused. You're gonna think it's like some of you did the step 2 CS or some others did like, perfect for, a history taking and a physical exam in a simulated setting where you'll have like 20, 30 minutes to talk to a patient, take all the social history. It's not gonna work. You really have to be focused in your questions and in your exam. You're likely gonna spend 15 minutes in each patient room the first month. The goal is to get down to 5 minutes when you're pre-rounding on your patient. So let's say the patient is here with shortness of breath. I'm not gonna ask much about their stool color. I should not be asking if they're having dysuria. I should not be asking if they have, for example, numbness in their legs. I should focus on the lungs. So shortness of breath, how does it feel like? Are you able to lay flat? When you walk to the bathroom, did you feel short of breath? Did you have any cough, any chest pain with it? Focus your symptom on the main problem. Of course, if the patient has other issues, you have to try to ask about them too, but don't ask everything. The way to do it is because you're gonna forget your patients when you're running between rooms. Before you enter into the room, open up that piece of paper you have and remind yourself what was like this patient's problem. Oh, okay, this is the guy with the heart failure. Okay, put it back in your pocket. Go in and like focus on asking about heart failure. Exam as well is also be focused. So you have to listen to their heart, listen to their lungs, check their legs for edema, check for JVD. If it's a different problem, let's say the patient is here with a GI bleed, okay, it's kind of you if you want to listen to their heart or lungs quickly. You're not gonna be like spending, 5 minutes listening to the lungs. You should actually focus on their belly exam, asking about the stool color. If needed, perform a digital rectal exam. If another patient is here with a neurologic issue, actually you should only spend your time neuro exam because it takes by itself 5 minutes. So you should be just doing the neuro exam. So that's why it's important to do a focused exam. If you tell me, what if it's a new patient coming through the ER? This is different. If it's a new admission for the first encounter, you have to do it full. Because after that, you just focus on the areas you want to focus on and don't waste your time. So let's say I examined this patient with heart failure and I heard crackles on their lung and I saw edema in the leg. Okay, perfect. You go out of the room. I would usually like at that same paper, I'll write down just I usually have it divided into columns. I write down like edema crackles bilaterally, BL. So I remember when I present this patient around what I had on physical exam, because you could forget it by 2 hours later when you saw like nine other patients. At the end of the year, you don't need this paper, maybe. Just memorize everything. You still gonna need some form of paper, but you don't write anything. That's the way you want to know if you mastered your intern year. I usually tell the number of pages and how much you write on those pages correlate with how your progress is during your residency. The smaller the paper numbers, and then the minimal you're writing, that means you're better now at memorizing things and you got used to it. If any of these patients you're seeing look very bad, like they're sick, they're huffing and puffing with shortness of breath, you think they're not doing well, their blood pressure is running low, don't just wait around an hour and a half later. Call your senior immediately. If you're worried, they should be worried. And it's never bad to raise false alarms. I always loved it when an intern's like, I'm worried about this for us. Who should do you want to take a look? It's like, even sometimes I know that what they're worried about, I might not be worried about, but I'm glad that they raised an alarm because that is a good skill to know that the trajectory of this patient is not doing well. And if you catch it before that all of a sudden the bomb explodes, that's important. That's a very good skill. So always escalate if you have that. So let's say you're done pre-rounding on 10 patients and you wrote those small pieces of information. You have those valuable papers. That's going to help you when you present. Now it's the time to present. Let's say, yeah, attending is here. It's 8 a.m., 9 a.m. And it's time to go round on patients. How do I deliver all these info I wrote down? It can be hard. So there is an organized way I usually suggest. The first thing to do with every patient outside the room is to start with a one-line summary statement. So let's say this is a 75-year-old male with heart failure with reduced ejection fraction who came in with worsening dyspnea and legs edema after running out of diuretics. That's a one-line statement. It will take you time to come up with a beautiful one-line summary statement for each patient, but this is a very simple one. You can say at the end of it, found to have acute heart failure exacerbation being diuresed. So that's the one-line summary. You start then with the same organized way you wrote down your information. Major overnight event. If nothing, just say no acute overnight events. There's something, well, his oxygen requirement increased. He's now on 2 liters. Then you go to the subjective part. So what did the patient report? They feel worse. Now they cannot lay flat at all. Now they need 4 pillows. He couldn't make it to the bathroom without getting short of breath. Or it could have improved. So that's the subjective part. What did the patient say? Now you go into the objective part. Objective means it actually should have supporting data for it. And you start with the vitals. As I mentioned, you use trend, I have suggested. If this is a heart failure patient, the vitals don't only include the common things, it's helpful to know what's called the ins and outs. So usually if they have heart failure, the nurse will be writing down how many milliliters of urine did they make and how much water did they or liquid did they drink. So you have how much input, how much output. And we need to know that maybe our diuretics are diuresing and thus the net is negative or not. Maybe we need more and the net is still positive and guys are doing a horrible job with diuretics. That's one more thing you need for your heart failure patient. Then after the vital presentation, you talk about your physical exam. You're not gonna tell me the fully normal things, okay? This is also focused presentation. Just tell me pertinent. It could be as the exam is notable for bilateral lung crackles, jugular venous distension, plus one legs edema. That's more than enough. If there's something pertinently negative, you should have to mention it. Let's say that this same patient is who had the also COPD with the heart failure, like there's no wheezing, for example. That's a pertinent negative. Next section is the data. This is the section you wrote down, the labs, the imaging, procedures. And you have to be organized in presenting it. Do not interpret data while you're presenting. So that means if you're going to tell me the hemoglobin or the creatinine number, don't tell me that, for example, the creatinine is going up and this is likely from the diuretics you gave. No, this is not a time to interpret data. Your job here is just to present it. So tell me the number, tell me the trend if it's relevant. Tell me if there's any procedure or imaging that was done, and that's it, don't interpret. Now we're done with the objective part. Now it's time for the assessment and plan. You again start with the one-line summary. It's always helpful and refreshing when we went through all this data to tell me. So in summary, this is again our 75-year-old with heart failure with reduced ejection fraction, with ejection fraction of 30%, was presenting with dyspnea after running out of his meds, found to be an acute heart failure exacerbation, not responding to diuretics. Then problem number one, now you have to start with your problems. It's gonna take you time to organize your problems, and your senior is gonna help you during that process. But the problem number one is likely gonna be the acute on chronic heart failure. And it might be the number one problem today, and tomorrow it's fixed, and the patient is now having very bad AKI. Then problems could change on a daily basis. So try to reorganize your priorities for problems. But let's say you say the problem number one is acute on chronic heart failure. You're gonna first, when you present this, say, what's the likely cause of it? In this case, you think it's likely because the patient ran out of diuretics. The second thing is like, this is evidenced by, what's your supporting evidence for this problem? This is evidenced by edema, pulmonary edema, legs edema, JVD. I always like to say that are things improving, not improving. Well, it's been on diuretics without improvement or with improvement. Next will be like, what's your either more workup that you're planning to do or your plan? This is something you'll discuss with your senior. It's hard for me to go over today. In general, over time, I want you to improve your terminology. So sometimes you'll say the problem is shortness of breath. It's okay. But if the patient's on oxygen, a perfect term is acute hypoxemic respiratory failure. That's the right medical terminology. I'm okay with you writing shortness of breath. I'm okay with you writing, pulmonary edema. I'm okay with writing heart failure. But if you want to optimize, this is acute on chronic heart failure with reduced ejection fraction. So try to always keep an eye on other notes. That's also another when you see your senior, when they admit the patient on themselves, writing a better note or more beautiful, just say, well, how did they make it better? Now, after you suggested your plan, you're discussing it with your attending and your senior, they're going to start telling you what to do. And it's very easy to just stand there and listen to them and not write anything and thinking that you remembered it. And then by after 10 patients, you forgot what to plan for the first patient. To have a pen and always write checkboxes. So increase Lasix to 60 milligrams 3 times a day. Repeat the potassium magnesium in the afternoon. Whatever they told you, write it down. You're gonna forget. And then that will come back at you if you don't do your to-dos. So do it. So let's say you finished the 10 patients. Now you're done with rounding. What should I do? The first thing is finishing those checkboxes. So come back to your workroom. Try to see, first, do I have to call any consultant? Do I have to call cardiology for that patient? Do I have to call GI for the other patient? Do I have to call neurology for the third patient? That's the number one thing to do. Call consultant. Because if you call me at 3 p.m. versus you call me at 11 a.m., I'm more likely to give you immediate answers by 2 p.m. If you call me early, I might likely tell you I'm not going to give you answers till like 7 p.m. and you could be gone by then. Okay. So call a consultant early. Then finish up your to-dos. Then you should have time to go, grab food, attend conference, and then at the end of the day is the working on notes where it's another thing we could later on talk about. And then you have the sign out part. So let's say you're done with your notes. Now you have to prepare a sign out to give to the night float team who's going to take over your patient and overnight cross cover them. So it's usually you and your senior organizing. There's in each hospital a way to do that sign out. Whether you use Epic, there's a way in Epic where you write the summary paragraph. You remember that one line summary? It's the same, but you add something. Well, the patient over the last 24 hours has been getting worse and now on 2 liters of oxygen. We've been increasing diuresis. That's a sign out. Do they have anything to do? For example, I'm telling them that we're gonna check his potassium and magnesium at 8 p.m. Please review the results and give more potassium and magnesium as needed. That's the to do for night float. And always the end of sign out is ifs and then. The ifs and thens means what if something bad happened to the patient? What do you expect it to be? For example, for the heart failure patient, if something bad's gonna happen, he's not gonna respond to diuretic, he's gonna get more short of breath. I can tell you, if he gets more short of breath, get an X-ray, increase the oxygen, give him a high dose Lasix, 120 milligram once, and then consult the cardiac ICU. For another patient, it will be if he's bleeding more, call GI, transfuse 2 units of blood or 1 unit of blood. So this is the if and then. And this is usually how the typical day should go about. It's gonna feel long for the first, week to maybe first month even, but you slowly get efficient. Don't cut corner about it. For my first month, I usually used to come in at, you think can be too much. I used to come in at 5 a.m., leave at 8 p.m. because I was slower, like chart checking patients. So some other colleague, maybe they could finish each patient chart checking in 5 minutes, could take me 10, 15 minutes to chart check a patient. Pre-rounding and talking to a patient, examining the patient, it could take me 15 minutes. So if I'm gonna be spending like around 10 minutes per patient chart checking and 10 minutes to 15 minutes examining, that's like 25 minutes. If I have 10 patients, that by itself is 4 hours. And if round is gonna be at 8 or 9 p.m., and I have a lot of patients, I'm gonna have to come early to do it. So plan ahead. You realize it feels too much, but then over time you'll be more efficient and you'll be able to do each patient in 4 or 5 minutes. And that's when we know that you mastered your intern year. But early on, I actually sometimes feel frustrated if I have an intern who knows that they're slow, that they need to improve, and they're still trying to, just come in at 7 a.m., which is the latest you would expect to show up because that's the sign out latest time. So if you come in at 7 a.m. and you know it takes you like 30 minutes to see a patient, round is at 9 a.m. and you have 8 patients, 6 patients, and you're not going to be ready by then, maybe you should have came in at 6 a.m. Okay. Although they tell you the sign out is 7, doesn't mean you should be there at 7. You should be there earlier because if you have a busy list. So be organized, but also be smart about how much time you need. Because if they notice that you're consistently, late on in terms of like, I didn't see all these patients. Sorry, that's fine. I'm gonna tell you, don't worry about it. You didn't have time to see these 2 patients because you were busy in pre-rounding. Don't worry about it. I saw them already. I'll present them and write their notes. But if I keep doing that for a week, I'm gonna sit down and tell you that, man, maybe you should come in earlier, because you're still trying to learn your system, and it's better for you to come and spend more time. And then that's how, if you keep repeating this, you'll be more efficient. That will be the best way to get efficient. It's just keep doing it again and again and again. So invest even that month or two, coming in early, leaving late to get this done right. And then you realize afterwards how helpful it will be. So that's for most things. I think if you're admitting, it might be a bit different because you have new patients assigned to you, but at the same time, you don't have that high number of patients. You might have like three old patients to see, but you're gonna get three new patients. So it will be similar system, but there is also the admission order process. Usually your senior will take care of that. Like they have to talk to the ED about the sign out for the patient instead of taking it from like the night flow to cross covered overnight. ED is gonna give you the story. You have to fully take a history, fully examine, because it's the first time you're seeing a patient. And then you write a full note. It's not like a full up subjective patient's doing better, doing worse. Like you have to write actual HPI. Like this is the shortness of breath started 3 days ago. This is the information. He tried this, he tried that, didn't work, pertinent negative, pertinent positive, and review of systems. All of this should be done. So that's how it's different on the admission day. Another last thing is the discharge process. You don't want to sleep on your patients forever. You want to send them home to clean your list safely, though. So if you know someone is getting ready to be discharged, these are the patients I also want to see early on when I pre-round, like after the sickest patient. I'll go to check on these to make sure they still look okay for discharge. I won't be surprised that at the end of the day, oh my God, they're getting worse. They're not ready for discharge. Damn it. So take a look at them. Ask them what their pharmacy is, what because you're gonna send them discharge medication. So usually the nurses are good at having it on file. That might be good to ask. And then try to prioritize the orders for discharge on these patients after you round. These are like calling consultant, discharge orders. These are the two most common things where you put those medication orders. Mainly the medrec is the hardest part. This is the home list they came in with, and now we're gonna discharge them. What are we changing? Are we going up on the dose? Are we stopping this? Are we starting a new medication? This is the hardest one to do, and it's always good to have your senior after you do it take a look at things because you want to make sure you send the right dose to the right patient. So seniors usually double check all of these regardless, or do it themselves with their PT. But it's helpful to do it at least a few times and have your senior supervise it. So I'm gonna stop here. Um, I hope I know it's too much. It's fine. I usually, try to share this with my interns many times during their intern year. You're gonna hear it likely many times about what's the best system to be efficient. Each one has different style. This is the style that worked with me, and I taught to many students and interns and residents. And you're welcome to also ask other people who you work with if they have a beautiful, efficient style of doing things. Build up your own, fine tune it, and you'll get better slowly. As long as you use some organized system, it's not like you're coming in out of scratch, opening Epic and hoping for the best. It's not going to work. As long as you have an organized way of doing things that cover all the boxes, it's good. Like I usually start with this tab, then I go to this tab, then go to this tab, then this. So as long as you cover everything in a checkbox, it will work. If you just hope by random you write the right things, it's not gonna work. So if we have no questions, gonna go back to Arslan was asking about how to get to GI fellowship. So as I mentioned, first is being an excellent resident is the key thing, and balancing your internal medicine residency goals with your fellowship goals. So not only that, I was trying hard to, stand out as a resident, as an intern, keeping a good reputation, learning, being proactive around being a good intern, but also being productive in research. I published two case reports within the first 6 months of intern year. I connected with the research mentors. I started research in January. Like for you, it will be like the beginning of second semester of intern year. And I kept into, asking for in the second and third year for GI electives because I want to get more exposure to this field. I want to also connect with the mentors. That will help when time comes for letter of recommendations, or also support. And if you think that you're just gonna be the cardiology resident or the GI resident who just focus on these rotations and do bad on all other rotations, you're not gonna match. It's very common. People will just focus on, oh, when I show up in that month with GI, I'm gonna kill it. I'm gonna come in at 5 a.m. when you barely came in at 7 a.m. on the internal medicine wards, and then I'm gonna stay there late and show them that I'm excited. And people think that you can fool, a service like that. It doesn't work because your reputation is double checked. Like when you end up interviewing for fellowship, it's different. It's not like residency when We don't, we can, there's no way you can verify what he or she wrote. They can this time because your program director is going to write you a letter of support for all residents for your fellowship. They are usually based on what everyone says about you because each residency program, they're going to have a committee that evaluate the performance. It's not only based on the evaluation by your seniors, by your attendings, but also by other things you've shown or any complaints that came about you. So if you always have been having great performance, everyone liked working with you, everyone like wished they would have you on their team anytime they're doing a rotation. Or on the other hand, it's like, okay, he was okay. I would encourage that they would be more proactive or learning on this rotation. That will look bad when your program director writes you a letter. Another thing is when you're try to plan your GI fellowship or any fellowship application, is try to prepare for the application early, like in the beginning of the second year, because that's when you're going to have to pick who are my letters writers, what the personal statement is going to be like, and others. So invest that, organize your plan early in second year to do this. And if you're doing well, you're doing good research, your program director and mentors at your institution were saying good things about you, you'll do well into the fellowship application and you'll match. Vice versa. If you're just balancing one over the other, it's not going to work. Matching at Baylor is different. It's like a constellation of things between. It's more like how to match into residency, which you guys have done, which is USMLEs, elective research, and then other extracurricular activities, and then coming up with a nice perspective, networking, having observership connections to these different sites. Citizenship versus visa plays a role. So that's the topic you guys already know about. Fellowship, it's relatively the same, but the circle narrows down. So they can easily know you. They can easily talk to your mentor who wrote you a letter. And if they blink for a second, who was this person? That's that. So you should be remembered. So I think that comes to the end of the time for this webinar. I hope it's helpful and thank you for attending. I want to wish you all the best in your upcoming intern year. I'm sure you're gonna do great. It's a nerve-wracking, but it's also exciting. You're gonna look back at it after you're done, and you're gonna be laughing, and you're gonna say, "I that was the best year of my entire medical training." So give it its max effort and enjoy the ups and downs. And then I have no doubt you're gonna do well, and you're gonna learn, whether you believe it or not. All the career goals that you have with their fellowship and others will come to be fruitful. And we have resources here with the match guide for those who are interested in fellowship application, who want to have one-on-one or they want to have review their application. So also take advantage of your own program if they have other people to mentor you with that. So with that being said, enjoy the rest of your day, guys, and hopefully gonna be a amazing intern year to look back at the end of your residency. Thank you.